All right, so let's go to the ketamine stuff. Ask questions as we go. We're just gonna do it freestyle, all right? But my goal is to make sure that you understand what ketamine is, its benefits, its risks. Basically, just get a good feel for it. This is the bird's eye view of ketamine. So ketamine honestly has such a great reputation and such a bad reputation at the same time. Especially, this has been highlighted by the recent death of Matthew Perry, which the coroner ruled as an overdose on ketamine. I disagree with that after looking at the autopsy and all the other stuff that was going on, because in general, ketamine is super safe, especially at the doses that's used for the treatment of depression and other kind of mental health conditions. If it's used appropriately and responsibly, it can be very safe, but it's not without caution that people should enter into the realm of ketamine. Now, the first thing I wrote on the board is days, not months. I'm gonna let the car go by. So days, not months. One of the main strengths of ketamine is how fast it works. Because if you look at almost any of our mental health treatments, they take a long time to work. And the ones that work rapidly, we don't want the patients on all the time. Think about it. Every patient that comes in this door, if they're on a benzo, they love their Xanax. You know why they love their Xanax? Because it gives them results quickly. They feel anxious, I take my Xanax, I don't feel anxious. And that'll last for this amount of time, and guess what? They gotta take another Xanax. And now we're combating addiction type of behaviors because of the properties of benzodiazepine. When patients take their Adderall, and they can't focus, and all over the place, and they take their Adderall and they're locked in, people don't no show for my Adderall appointments because it works, and it works fast. It's less risky than, say, a benzo long term, but it's not without its risk of abuse potential. Ketamine is similar. Ketamine works fast, it works great, it's powerful, but here's the good thing. Patients don't have access to it outside the office. If you prescribe it responsibly and you confine it to your office and you limit patients' access to it, it can be very safe. It does not create a dependence for the patients. Okay? So there's no withdrawal. And now I have the closest thing I had to a magic bullet to help my patients with depression, anxiety, post-traumatic stress disorder, OCD. Because I know that I can rapidly reset how the brain's working. And I got a completely controlled environment to do it in, right? So one of the main things is the fact that I can get somebody better pretty quick, but where did ketamine come from? So I think a lot of people think about ketamine, they think about, oh, it's a horse tranquilizer, or it's a street drug, Special K, right? But I've been in medicine long enough, and I can't say that I'm an ER doctor, so if you're an ER doctor, it may be different. But in medical school, and throughout residency, and doing internal medicine and everything else, I had never seen anybody come to the hospital with a ketamine overdose. Now that may be different now, because ketamine is becoming more popular. But in general, you don't see a lot of people addicted to ketamine. All of us know somebody who was addicted to alcohol or got in trouble for that. You know people that got addicted to weed, got addicted to, cocaine or crack during that epidemic. Everybody knows somebody who got addicted to opiates. Hardly any of us know somebody who's addicted to ketamine. And I think that kind of lets us know like some of the properties of the medicines of how it's operating in the community. But really, ketamine was synthesized back in 1962, right? And it kind of was the offspring of some research that people were doing on like LSD and PCP and things like that. And they discovered the molecule, and I'm like, oh, what is this for? They kind of sat on the shelf for a while. It was later tested in animals and then, later in humans, and they figured out, wow, this is a great anesthesia medicine because it has some pretty unique properties. One, at the right dose, unless you get the mega doses, it does not suppress your drive to breathe. That is super important. That's the only reason that we do it in mental health without the assistance of an anesthesiologist, because I don't have to worry about respiratory depression while I'm giving people low dose ketamine. Okay. Now, once you get the mega doses, of course, you need an anesthesiologist and things like that. But in the psychiatric realm, we're only using low dose ketamine. Okay. 2, it supports the cardiovascular system. Okay. It increases cardiac output, right? It increases blood pressure. And 3, it doesn't have that same type of addiction pattern you see with, say, opiates, because there's not a physiological dependence to it, which is awesome. And 4, even though it's considered a side effect, you get dissociation. And like, why the heck would that be a benefit? Well, let me tell you why. The reason ketamine became so popular, in fact, ketamine right now is one of the 10 essential medications identified by the WHO. So if there was a worldwide catastrophe and we only could take 10 medicines, ketamine is going to be on that list because of these properties. And it really became popularized during the Vietnam War because it was created in '62. And since ketamine is highly portable and it can be given through many routes of administration, it can be given orally, it can be given rectally, it can be intramuscular, it can be intravenous, it can be inhaled, right? This became a big buddy medicine during the Vietnam War. So imagine you were shot. Oh, I'm hit. You're gonna have a lot of pain. You're gonna be panicking. You're scared for your life. So what the medics would do is give someone a shot of ketamine. Because 1, you don't have to worry about the patient stopping breathing. 2, you're bleeding out. I need your cardiovascular system to work well to keep perfusing your brain, right? I don't want your blood pressure to drop. 3, it causes this dissociation or separation from the event so that it diminishes the fear response, okay? Oh, and I forgot. It works great for pain. So it's an anesthesia medicine. So how did it go from being a buddy medicine in the Vietnam War to in a psychiatric clinic? Well, it didn't start there. So after the Vietnam War, this became one of the most commonly prescribed anesthesia medicines. So you see it a lot of time with induction of anesthesia along with other medications. Because it also helps with amnesia. So at higher enough doses, sometimes patients have amnesia for the event. So if you're going for a really major surgery, they're going to give you enough ketamine. You can do your surgery, be unconscious, and you ain't going to remember none of it. Because sometimes patients wake up out of anesthesia. But ketamine can kind of minimize the risk of that, right? So for the longest time, it's primarily been used as a pain control agent and an anesthesia medicine. But about 20 years ago, there was an observation that patients were going for surgeries, and when they wake up, their depressive symptoms will be better. Then that lasts for a few days or a few weeks, and then they kind of relapse back into depression. And some clever doctors noticed that, and were trying to figure out why the heck are patients waking up from surgeries talking about they don't have depression anymore. And they discovered it was the ketamine and the anesthesia that was causing that. So if you look at a lot of the early studies on ketamine, they were kind of playing around with the doses of what could cause that effect. And most of the studies kind of landed on this 0.5 milligrams per kilograms of body weight as a starting dose for ketamine in the mental health realm, which is very different from what you see in anesthesia, where they may get 10 to 15 milligrams per kilogram of body weight. So we're using like a fraction of what you use in the anesthesia dose, right? So most studies will point to that 0.5 milligrams per kilogram of ketamine administered to a patient in an induction phase and then the maintenance phase. Typically in the induction phase, patients are doing 3 treatments week 1, 3 treatments week 2, or they may do 2 treatments per week for 3 weeks. So usually 6 treatments is the most common protocol, spread out over 2 to 3 weeks. Okay, at the doctor's discretion, it may be different, but at our clinic, we typically do 3 and 3. Okay, so after the induction phase, typically patients will have the result that they want, or a resolution of depression, reduction in anxiety symptoms, if they can tolerate the treatment, which is very attractive in a world where most of the time we're waiting 4 to 6 weeks for an antidepressant to work. So if I have a patient that has acute suicidal ideations or very severe depression, or I've had patients come in, I'm going on vacation, I ain't been on vacation in 20 years and my depression's bad. I want to feel good for my trip. We're leaving in 3 weeks. I know that I can get them better more than likely in those first 2 weeks of doing treatment. Oftentimes patients may respond as early as 1 treatment. Okay. Now, mechanism of action. So on the Spravato talk, we talked about the mechanism of action. So it's similar. It's an NMDA receptor antagonist. So remember the NMDA receptor are primarily on what's called interneurons. Their job is to regulate the firing of the brain. They can act like a parking brake on the brain. Okay, and it tells the nerve cells not to fire. If you look at the brains of depressed people and you put them on a PET scan or a functional MRI, and you compare it to a person without depression, you're going to see a normal brain lit up, lots of activity. Depressed brain, lots of dark blue colors because there's less activity, especially in the front part of the brain. If you do one of those spectral EEGs, looking at the brainwave activity when patients are depressed, the brain is going slower. It's not firing like it should. That's because the parking brake's pulled up. That's one reason. So what ketamine does is block this NMDA receptor, allowing the nerve cells to fire more freely. It works best in adjunct with the other antidepressants. So think of antidepressants like gas in the car. Think about the NMDA receptor like the parking brake. Think about ketamine as something that removes the parking brake, but you still need gas in the car. So they work better together. When we remove this parking brake, it increases glutamate in the brain. Glutamate is excitatory, tells the nerve cells to fire. When there's more excitation or firing in the brain, you get a release of something called BDNF, or brain-derived neurotrophic factor. This is like fertilizer for the brain cells. It tells the nerve cells to grow new connections, right? So one of the beautiful things about this is I have something that can predictably create an environment in the brain that makes the brain more neuroplastic. When the brain's more neuroplastic, it has a better ability to learn. Like we need patients to learn how to speak to themselves, how to relate to themselves, how to interact with the environment. And when the patient is depressed, the brain is static. It is concrete. That's why you can tell a depressed person over and over again, you are enough, you are loved. It's not like that. We in your back. And they're like, no, it ain't. They don't believe it because the brain is concrete. We're turning it to a plastic brain so they can learn and they can change, right? And that's one of the beauties of ketamine. So with this increased excitation, this opportunity for neuroplasticity, you create what's called a critical window. So the word critical window is usually associated with early childhood learning. So that 0 to 5 window. That's where kids pick up language the fastest. They grow the motor skills the fastest. They pick up their social skills. That 0 to 5 is the most critical time of learning because the brain is highly neuroplastic. And it's hard to recreate that. And there's only a few things that can do it, and ketamine is one of it. Also, the other psychedelics create critical windows too. And it's directly related to the half-life of the medicine. So typically, ketamine will create a critical window between 24 to 48 hours because the half-life is relatively short. Versus say something like psilocybin may open that window for a week or so. Right? But obviously we're not using psilocybin or MDMA at this point. So ketamine is the closest thing that we have to a legal psychedelic that creates a neuroplastic window for the brain to change. And irregardless of this psychedelic effect, it has a direct effect on the brain cells that's not necessarily connected to the kind of psychedelic effect that ketamine can have. So that's a good segue to talk about what the heck is the experience when someone does ketamine. So it depends on the route. So our clinic, we do intravenous ketamine, intramuscular ketamine, intranasal, but only with Spravato. We don't do nasal ketamine in our office. There's an oral version of ketamine that only selective patients have access to. We typically use that as an adjunct antidepressant. Unlike, say, companies like Mindbloom or some of the at-home ketamine programs that may give you a really high dose of ketamine, I feel like, in my opinion, higher doses of ketamine should be supervised in the office. So if we do a higher dose of ketamine, we only do it here in the office orally with a therapist for ketamine-assisted psychotherapy. And we make sure the patient is back to their baseline before they go home versus giving someone 900 milligrams of ketamine on their couch while the cat's watching them for their treatment. However, our primary route is IV. So what I kind of want to show is like a dose response curve. What that means is like, when does the medicine kick in? When does it wear off? Because it's slightly different based on the route of administration. So IV ketamine, I feel like, is the smoothest ride. So if you ever rode a ride at Disney and the kids will say, oh, we're going to get on a roller coaster at Disney. There ain't no real roller coasters at Disney. Those are smooth rides, all right? You haven't been on Magic Mountain, that ain't really scary. So IV is kind of analogous to that, where there's kind of some distinct phases that patients go through when they do a treatment. I'm going to write them up here. Phase 1 is the relaxation phase. Phase 2 is what I call a trance phase. Phase 3 is what I call a transformation phase. And then there's a resolution phase. Okay. So when the patient's first starting getting ketamine and the medicines get injected intravenously, typically, obviously, since you're putting directly in the bloodstream, it doesn't take long for the patient to start noticing something is different. That's the relaxation phase. Since this is an anesthesia medicine, typically people will just feel relaxed. They feel more calm. Their limbs feel more heavy. They're kind of sinking into the chair. They're fully aware. They're fully in control. But they can tell they're getting some medicine. So it's typically like this. Then they start noticing that the medicine is altering how they're thinking. So they may notice things like, I never noticed this crack on the wall. Wow, it's kind of beautiful. It looks like a tree. And your brain starts making connections to things they wouldn't normally connect. And like, I've had patients say, wow, the light looks so beautiful just coming through the windows, and they notice the individual photons coming through the window, and you see them all the time, but you never pay attention to them because your brain's starting to make new connections and seeing observations they didn't normally see. So trance phase is when patients have a clear alteration in how they're thinking, but they're still in control, right? They still feel like they're in full control of what's going on. And then from the trance phase, they kind of reach what I call the transformation phase. Transformation is when you're not in so much control anymore. The way that you're thinking is altered. It's like dissociation is most likely to happen in this experience, and it can vary from person to person. Ketamine is not an experience like a psilocybin where people are seeing all these vivid colors and they're seeing pink elephants and they're having these complex visual hallucinations. That is not a ketamine experience typically. Ketamine is a very internal experience. It happens in the mind's eye. A lot of people describe it, and it's a wide range of what people describe, where oftentimes they may see colors behind their eyelids in their mind's eye. They may see fractals, that may transition to more complex things in their mind's eye. So typically I've had patients can tell me things like they just feel connected with the universe and connected with things around them. They feel themselves maybe transforming into other things. Like one of the doctors I treated, she said, I felt like I was transformed into, what was it? What's the word for the, it's like mushrooms. It's myconium. What is it? What's the word for the mushroom seeds? I can't think of it right now. But basically yes, mycelium. So she basically felt like she had turned into a fungi, and she felt her roots going down into the earth, and the earth was feeding her, and then she was just erupting from the ground and growing into the outside, right? So it was a transformative experience for her. I've had patients describe this connected with the universe, so they're flying through the universe or flying through the solar system. Sometimes you will see during the transformation phase more complex experiences. I've had patients who have unresolved grief with loved ones that's passed away. I've had patients have very spiritual experiences where they were able to make peace with their deceased loved one. I've had patients feel like they can hear clear directions from God. A lot of very spiritual experiences with ketamine. That typically happens during the transformation phase. This transformation phase will last for a period of time, and then as the medicine is completed, the medicine wears off and they kind of go in reverse through that trance and relaxation phase until discharge. So typically this experience will take, the actual treatment will take about an hour. The entire experience take about an hour and a half, about 90 minutes from time into the room, IV started, mentally prepared to start the journey, take the journey, medicine goes off, recovery time to make sure the patient is comfortable, the blood pressures heading towards normalization and ready for discharge. So usually we'll slot the patient for about 2 hours. That is IV ketamine, okay? The magic mountain. Then there's intramuscular ketamine, or IM ketamine. So for the average person, this is not covered by insurance because it's not FDA approved for these indications. So therefore, it's usually a cash cost. Everybody cannot afford IV ketamine. So to meet that gap, to leave the 99 from the 1, like we talked about, we came up with intramuscular ketamine. So intramuscular ketamine has a different experience. Think more Carowinds, right? I'm going to shoot to the top of the ride and you're going to drop me to the bottom, okay? So typically, the relaxation and trance phase happens so fast, patients don't perceive it. So typically, after the treatment, they pretty much, within about 7 minutes, will get to that transformation phase. It lasts less time, and then they resolve a lot quicker. So the treatment itself, if you just do one shot, usually about 45 minutes altogether, okay? That's usually in and out. So we usually can schedule for an hour, hour and a half for the IMs. Sometimes, however, for patients who need it, we'll give them 2 shots. So we'll ride the wave up. On the way back down, we'll give them another shot, and that'll get them back up to their peak and to make it more similar to an IV treatment. And if that's necessary, we'll do that, okay? But it's less expensive, easier to render, easier to monitor. So it's it's more cost effective for the patients, okay? Efficacy-wise, it's similar. I feel like IV is a smoother ride and easier to control for the patient. So when patients do intramuscular, once the dose is in, it's in. And if you overshot the dose, oh man, you gotta survive for the next hour, hour and a half. Because ketamine can be very, very pleasant, very, very transformative, very, very eye-opening, even though those are considered side effects. But it also can be very scary. It can be dysphoric if the set and setting are not controlled. So when I say set and setting, that means the patient has to be in the right mindset to do a treatment. So we're very cautious about prepping a patient for these treatments. And the setting has to be protective. So you're very vulnerable because you're in this altered mind state, all right? So the patient needs to feel safe. They need to be comfortable. So if it's too cold in the room, too hot in the room, that can affect their experience. If there's too much noise going on and they're getting disrupted out of this kind of experience, then sometimes that can kind of get them off the rails and they can have bad experience or a bad trip, okay? Typically, the way we mitigate that is, well, with the IV, you can turn the IV off. Ketamine has a relatively short half-life, and typically within 5 to 10 minutes, it'll start coming off and the patient will kind of come out of the experience. While IM, once it's in. So oftentimes we undershoot the dose and work the way up, and we have a lot of supervision for the patient so that we can, reassure the patient, calm the patient, monitor their symptoms, et cetera, et cetera. But typically when we do that start low, go slow process, we avoid those altogether, okay? And then there's oral ketamine. Oral ketamine has become popular because of the home delivery systems that they have. But typically it's closer to the IV, but not as profound. So I wish I had a different color. How do I do a different color? There we go. So if we did an oral, it'd be more like the IM experience, but usually milder. Okay. So there's definitely a difference between if you swallow the ketamine versus not swallowing the ketamine. So ketamine has metabolites that happen when you go through first pass metabolism, which will make it more likely to cause nausea if you swallow it because of the metabolites, and it lasts a lot longer. Okay, so typically I'll tell patients to swish it, retain it in their mouth for 5 to 10 minutes, and then spit it out. Okay, some patients can tolerate swallowing it, and you can use a lower dose and it lasts longer, but that's not for everybody. That's something to be conducted in the house. Okay, so that's kind of the experience with ketamine. Side effects. So side effects to ketamine are similar to Spravato, but more intense because typically the dose is higher, and we have more range on the dose. Okay, however, the treatment is shorter. Okay, but the most common thing you'll see is dissociation. I don't know if we can see that in red. Let's do yellow. Blood pressure increase, cognitive changes, sedation, respiratory changes. Typically, like we monitor the pulse ox. I never see pulse oxes go down for the most part. It has a potential as a respiratory depressant. And a lot of patients are on benzo, so we always monitor that. But typically in the dose range, you don't see respiratory depression. Okay. If the dose is too high, you can see a seizure. So a lot of times in our medical clearance, we want to check for their history of seizure. That's super rare. I've never seen a seizure with ketamine. Okay, but it's possible, so we always look out for those things. Headache. All right, I said blood pressure increase. Tachycardia, so increased heart rate. That's possible with that, and we kind of monitor those things during the treatment. But probably the most prominent and the most common is going to be dissociation blood pressure changes. Okay. Impact. So how well does this work? Because who cares about all that other stuff if it doesn't work? So the good thing is that if you look at most conditions in the brain, it's either the brain's running too fast or it's running too slow. I mean, that's what it is. You're depressed, or you're anxious, or you're hypervigilant and PTSD, and you got other parts of your brain that's running too fast. So what we're doing is kind of breaking up the pattern that the brain is operating. So the good thing is it has impact on a variety of different conditions, right? So it's not a panacea. It doesn't work with everything. I think it works best with depression. I've seen it do well with OCD. I've seen it be helpful for PTSD. But depression is kind of the main thing it works well on. Okay, that makes sense because depression is when the brain's slowing down. Okay, but my expected impact is greater than 70%, and you'll see a lot of different variety of numbers in the studies. And it depends on how the study is done. If you take all the medicines off and no counseling, you just do ketamine, that number's going to go way down. But if you do it in conjunction with therapy and antidepressants, our standard of care, supportive environment, yada yada yada, you see greater than 70% improvement rates with it. And the good thing is I'm going to know it's going to work within 2 weeks, which is great. So for me, I feel like ketamine is a great option for patients who can tolerate it. So that begs the question, who can't tolerate ketamine? Number one, patients with psychosis. It is not for them. So we think psychosis may be from excessive excitations in parts of the brain. That would explain why they have auditory hallucinations and things like this. So if we put ketamine on board, it's going to exacerbate their psychosis. So any psychotic illness is a no-go. Okay. Now there's a difference between patients with PTSD that hear things because that's their PTSD. It's not a psychotic process. So it's still more appropriate for them. Okay. Unlike Spravato, so Spravato is not for bipolar disorder. However, ketamine can be for bipolar depression, but I typically won't treat rapid cycling depression. Rapid cycling bipolar. So rapid cycling is a patient that's going to have a manic episode more than 4 times in a year. Because there's a risk that this may actually trigger a manic episode, or worst case scenario, a mixed episode, which can be very dangerous for a patient. All right, since you're on students, here's a pop quiz. Why is a mixed episode of bipolar so potentially dangerous? Well, y'all have suicidality.
You're cycling so much. It's like you're going in and out even more, so you're just even more likely neurochemistry.
Okay, that's close. That's close. You were saying what?
It's just changes in the excitatory versus depressive neurotransmitters.
Why is that dangerous?
Because it can. Exactly.
Okay.
Sort of like
I feel like you're saying with the parking brake.
That's what's on the.
Yeah,
Up and down.
it's like you're stalling
Right.
and then you're taking off. You're stalling and taking off. It's like.
So that's what's going on underneath the hood.
You're
Okay.
getting energy and then you get depleted, so you don't know where in that phase you can find the energy to commit the suicide. That was.
Very, very, very close. Very close. You had a thought?
Similar to what they were saying, I was just thinking, with the rapid cycle, I feel like if you're at a high, I just feel like you'll crash more if you're having a rapid mix between high and low. It's just harder to maintain than, like I said, people who suicide ideations.
So think about what a mixed episode is. So a mixed episode is when patients have the increased energy of a manic episode, the decreased need for sleep, the goal-directed activity type of parts, but without the euphoria. They don't have the feel-good part. They just have the depression part, the sadness part, the self-destructive part. So if you have somebody with high energy and high goal-directed activity plus depression self-destructive type of thinking together, then you have a recipe for someone who has the energy, intent, and power to kill themselves. So that's one of the more dangerous things in psychiatry, is someone having a mixed episode with bipolar. So rapid cycling is a no-go for me with ketamine. Now other clinics may treat it, but I won't treat it. Okay. It's not for patients with cardiovascular disease. So if you have cardiovascular disease and you cannot sustain the potential increases in blood pressure, whether it have been previous cardiovascular like heart disease, previous MI or myocardial infarction, strokes, aneurysmal disease, AV malformations, anything that will cause like stress in the arterial tree and can cause problems, that's a no-go. Can't do it. Pregnancy, definitely not for pregnancy and breastfeeding. That's a no-go. Usually people who have uncontrolled seizure disorder, but I will treat people with seizure disorder if they're on medicines and it's treated. Okay, but if you have uncontrolled seizure disorder, I'm not trying to have our patients have seizure in a psychiatrist's office without that type of medical care available for them. Unlikely, but I think that should be a contraindication. Okay. Here's some relative contraindications. A lot of times patients on Lamictal and medicines like it, Lamictal competes for that NMDA receptor spot. So I still treat people with it, but it may reduce the efficacy of ketamine potentially. Some studies said that doesn't happen, but my observation in the clinic has been like, it seems like Lamictal appears to decrease the impact of ketamine, but it still can work. Okay. So patients need to know that so they have informed consent that if you're going to stay on your Lamictal, there's a chance it might not work as well. So once they invest that energy into doing the treatment, they don't want to be disappointed when you forewarn them. Okay. Let's see, anything else? Substance abuse. So patients with substance abuse problems. If a patient is like just coming to the clinic to be a psychonaut, they just want to know what it feels like, they want to experience it, they don't really have symptoms, that's not for them, because it's not, the potential benefit is not worth the risk of the medications. Also, patients with active substance abuse problems, I think may not be the best thing to do ketamine. Typically, patients who just like maybe use marijuana occasionally, things like that, it might be okay based on the patient and their stage of change. But if they're heavy drinking, it's probably not the best treatment for them because it's counterproductive. Because drinking suppresses the brain, and you stimulate the brain. Then they go home and drink, and they're on a seesaw. That's not ideal for the patient. Okay. All right. So in a nutshell, what we need to know about ketamine is highly researched. It's evidence-based. It works well in the real world. It works rapidly. Okay. It is not only mechanically changing the brain and how the cells are firing, leading to an antidepressant effect, but also there's an experiential part of ketamine where people have this disruption of how they normally think, especially when guided with therapy. It can kind of break them out of the thinking patterns that's making them sick. Okay. And we also can get people better within a couple of weeks instead of months, which is pretty impactful, especially when patients have acute suicidality. So if they don't need to go to the hospital, or they have a lot of suicidal thinking, they don't have intent, ketamine might be something that can be really helpful for them. Okay. And then finally, the properties of ketamine make it safe for an outpatient setting, because I don't have to worry a lot about respiratory depression and, they're having a fatal arrhythmia or something because the dose of ketamine is so low in the outpatient setting. So it's definitely a good option for the patients that are not responding to traditional means, who are looking for another option, or they need to rapidly get better. Okay, very good. Any questions about ketamine?
Compared to Spravato, did I hear that Spravato is contraindicated for seizure?
No, not absolute contraindication.
Not absolute.
Not absolute, but I would, want to look at their seizure history, their medicines and stuff like that.
Spravato.
Yeah, for both. For both. So remember what ketamine is. Ketamine is a racemic mixture of ketamine and S-ketamine. So when someone does a ketamine treatment, they're getting both of these medicines in one. So The reason that ketamine is not FDA approved is because it came out in 1962 and it's been all patent. So you can get ketamine for pennies on the dollar and any manufacturer can make it. So no pharmaceutical company is going to spend the millions and millions of dollars to an FDA trial to get FDA approval, and there's no money to be made. Ketamine will never be FDA approved for depression because of that. However, Janssen, a subsidiary of Johnson & Johnson, had the forethought to say, man, ketamine's working really good. Oh, what if we can just isolate the S-ketamine? We'll repatent that. Nobody has a patent on S-ketamine like that. We'll put it in a proprietary nasal spray. We'll do an FDA trial because I know it works because we're seeing people doing it already because at this point, 2019, there was plenty of ketamine clinics around at that time. They got the FDA approval and they just call it Spravato. So they basically took a component of ketamine and got it FDA approved. Okay, so they have very similar properties. This is a different experience because one is intranasal and absorption rates change. The dosing changes. So Spravato comes in 2 doses, 56 milligrams and 84 milligrams. Ketamine, you can just kind of do whatever dose based on what the patient needs, and it's usually weight-based. That's the foundation for it. And then it's adjusted based on the patient experience. Okay. Typically in our clinic, we won't exceed 300 milligrams. That's usually our cap for IV treatment. The reason for that is as you exceed that, then you necessitate more advanced cardiac monitoring to make sure the patient's safe. And I'm not a nurse anesthetist or an anesthesiologist, so we don't tiptoe in that range. So all our doses are less than that. Okay. So good question, actually.
Sorry.
Go for it.
Yeah, the oral is something when you go through the first pass, it breaks down the metabolizers. If that happens, do we have at the clinic something like an antiemetic, or we just let it ride?
Oh, that's a great question. So nausea and vomiting are potential side effects with ketamine, regardless, any route of administration. Okay. Typically, patients are instructed. So one thing we started doing in the clinic a couple years ago was we do a preparatory session. So the workflow is patients do an online screen. If they're qualified through online, they do a medical clearance. Okay. Once they're medically cleared, we put them on the schedule, but their first appointment is a preparatory session. In the preparatory session, what do you bring to the visit? What's it going to be like? What to avoid before, what to do to prep, et cetera, et cetera. We teach some breathing techniques, right? How to self-soothe, what to do after your treatment, and what the generic treatment plan and what your follow-up visit is going to be. Within that prep session, we teach the patients, do not eat or drink 3 to 4 hours prior to your treatment because of the risk of nausea and vomiting. Also, the more food in your stomach, the more likely you are to get nauseated, okay? However, I don't like patients to go all day. They didn't eat all day long. They're doing the treatment 3 o'clock in the day. Now your body's depleted, and the ketamine is going to feel a lot stronger because you have no fats and proteins because you done fasted all night and you fasted all day. That'll make the ketamine feel more impactful, and it's harder for us to kind of control the experience because the patient's depleted. Okay, so they'll learn all that during their preparative session. So to do that, some patients who get nausea all the time, we prophylactically treat them with Phenergan or Zofran. Or we'll do the orally disintegrating Zofran during the treatment if necessary. Some patients don't like that. We just let them thug it out and throw up in the trash can. But it can happen though. Okay. Now let's talk. Since you're talking about kind of mitigating side effects, also there are things that we do to control blood pressure. So even if the patient's blood pressure is normal before the treatment, if their blood pressure gets too high, the most simple thing we can do is turn the ketamine off if they're doing an IV. That'll correct the blood pressure in about 8 to 10 minutes. Okay. Otherwise, we may use like oral clonidine to help patients with that. We used to do like metoprolol, but I don't like to mess with the heart rate. So typically we'll just do clonidine if necessary. Oftentimes it's deep breathing will help correct it, because really what you're getting is ketamine acts like a sympathomimetic. It mimics the sympathetic nervous system, like having a fight or flight response. So that's why in the prep session we teach breath work. So sometimes I can just get patients to do breath work and that'll lower their blood pressure, okay, without having to use pharmaceuticals.
Sorry, the clonidine standing order is up at what, like 0.1, 0.2?
And you use 0.1 milligrams PO times 1 dose. Then BP, I usually do they worry about their blood pressure, we'll do it Q 5 to 10 minutes or something like that. And then we'll kind of see how it responds.
As long as it's below 150 systolic, we don't treat.
So prior to treatment, if it's less than 150, there's no reason to administer it. Unless you have somebody you know that their blood pressure shoots up to 195 or something, or 200. Like we have every once in a while, we have patients that blood pressure predictably goes up 50 points. I may pre-treat them before their ketamine. We've never had anybody have any serious cardiovascular event in the office in the 8 years that we've been doing this. Okay, but that's because of the selection process, being really strict about blood pressure control, and prepping the patients prior to the treatment. So a lot of times we tell people don't take stimulants, don't take a bunch of caffeine before, don't watch horror movies. All those things shoot your blood pressure up during the ketamine treatment. Okay, very good. All right. So that's ketamine in a nutshell. Now you can go out and treat patients and save lives, but ketamine definitely is a opportunity to be a hero in somebody's story, because a lot of people don't know about this yet, even though it's been out for a long time. So very good. Thank you for your attention.